Okay. So, okay. All right. Hello everybody. We're ready to start, and so we're going to have another discussion kind of workshop experience today, and so I was thinking of a topic that I thought would be interesting and relevant. So I hope that you find it so also. Shall I introduce myself again? No, I'm not going to introduce myself again. Okay. This is the really the third of a series of workshops in kind of grey areas in medicine. So the first one we did about 4 weeks ago was on where medicine kind of reaches out into kind of the limits, some of the limits of medicine, and maybe some places where medication is not necessarily the best treatment for it, or it needs a more holistic or a bigger approach to some situations. And those were kind of times in life or situations in life, for example, grief, or loneliness, or even things like changes in your kind of times of change in physiology, like the menopause, something like that. And I don't know if you remember, we had the case of a 78-year-old man who'd lost his wife about 8 months before, and we were in groups and we were discussing what would be supportive for him. And so that was the first one, and the second one that we did 2 weeks ago was on risk and uncertainty in medicine. And I was just wondering, from that one, has there been have any of you had some thoughts since that workshop, or some thinking things through, or some uncertainties or discussions? Or I was wondering what has what has kind of landed for you, or what you're thinking about since we did that one on risk and uncertainty. So we had a case, everybody's 78 in our cases, I think. So we had a 78-year-old woman, and her son was living 5,000 miles away. Do you remember that? And then had the first grandchild. And then when we had a bit of discussion at the end of that session, a couple of you said that you would maybe consider going for second opinions in some situations. And I was wondering if there are other thoughts that people had since that one. Anything? It's fine. It's the kind of thing that it may just catch you one day and you'll think, oh yeah, that makes sense, or that doesn't make sense, or that kind of thing. And then as the third of the series, it's really, I was thinking on grey areas in medicine. So these are areas which are not clear-cut, and there's not a definite clear-cut treatment. I would do this topic, medical tests that confuse us. It kind of came to me, and I thought, yeah, absolutely, this is something that we deal with. And it's not that, it can be quite not that rare, and we come across this. So right, I'm going to the okay. So this all comes from us as human beings, essentially. So we're going on the slide on the left. So as human beings, so one of the amazing abilities that we have as human beings is to have an imagination and a creative mind, and that goes into technological advances, and there have been incredible technological advances, and that has meant over the last several years, 30, 40, 50 years, a big increase in our ability to carry out all kinds of tests in medicine, all kinds of investigations, all kinds of tests in medicine, and really Many of these have been absolutely incredible. I mean, in terms of what we can do now that we couldn't do before, it's completely a different situation. So I've just picked a couple of examples, and you guys may have lots of other examples, but one is for example, in imaging of the brain, so scans of the brain. One is called, so there's functional brain scanning. So what you can do is match the areas of the brain that light up during the functional brain scanning with activities or actions. So, for example, you can, in neurosurgery, when they're doing an operation and they want to make sure that the vital functions of the brain are preserved, they can map onto the brain and make sure that those activities the areas are lighting up, and that is connected with preserving those vital activities. And for example, if you can see if somebody's feeling a certain way, if somebody's feeling happy, there'll be a part of the brain that lights up. There may be, and if somebody's feeling different, there'll be another part of the brain that lights up. If somebody with music, that may light different parts of the brain up. So there's all this amazing ability to really match in more detail the science with important things that we do in our life. And another of the amazing, just incredible game-changing advances that we made is our ability to unblock blocked arteries. So previously, I think maybe 30, 40 years ago, if somebody so if you have a heart attack, essentially that is a lack of blood supply to a part of the heart, and the heart muscle dies, a little bit of the heart muscle dies, and that's due to a blocked artery to the heart. Nowadays, all methods to unblock the artery quickly and preserve the heart. Previously, 30, 40 years ago, that was not done very much. So that is an absolute, revolution in the ability to protect the heart, preserve the heart. So that's awesome. And another area in terms of unblocked arteries, sometimes if people are having a stroke, that's also due to a blocked artery to the brain. They can unblock, so they see people having signs of a stroke, they can unblock that artery if they get in quickly enough, and you can preserve the function. So that's incredible. So that's a big upside. However, as with lots of things in life, there's also a downside. So with the upsurge of investigations, we get lots of results, lots of all kinds of scan results, blood results, other results, and some of them we don't really know what to do with, and in a way they can sometimes cause more anxiety than not knowing, and that's part of where the situation we've got ourselves into because of the advent of investigations. So in some situations, so it's important really, if you have something like an investigation in medicine, it's important to think through what are you going to do with the results that you get. What are the consequences? How are you going to manage it? How are you going to think it through? And sometimes with the push to get these investigations out, which do such great things in some situations, there hasn't really been the thought or the time to progress the thinking of how you're going to manage those grey areas. So, yeah, I wanted to bring this here because there's another area we need to think about, and it's not so clear cut, and we'll show some examples. Okay, and in a way, I put in this kind of a bit slightly sensational language, but in a way, medicine has got ahead of itself. In a way, it's like, great, we're going to investigate this. So nowadays, if you go into an accident emergency department, they've got CT scanners, and if you've got like abdominal pain or chest pain, you're likely to have a scan of your chest, a scan of your abdomen. 30 years ago, that would not be done very much. There were far fewer scanners. So something like CT scanning, that technology of CT scanning has improved a lot since 1990, 2000. So the initial scans that came in were quite coarse and not that detailed, but now you do multiple slices, so you can get lots of information quickly. So of course, if somebody comes in and you're not sure what's going on with them, why not? You just want to be sure in that sense and get the scan done. However, okay, so all right, so this is kind of flows through also through the previous workshops. So there's a dynamic that goes through. So one of the dynamics that's certainly coming into Western medicine and was active in the States, and maybe like in the UK system, which is the system that I work in, we're 10 or 15 years behind the States, and South Africa would be similar. That there is a so if you're in the physician's shoes, one of the big pressures on you is that can come at times is not to be litigated. Okay, so obviously you want to do the best by the patient. That's your ethical responsibility. It's your primary responsibility. But you also, somewhere in there, God forbid if there's a problem, you don't want to be you don't want to be, you want to have been seen to do all the right things, but sometimes doing all the right things is doing lots of tests. So that's part of the dynamic to do that. And then together with that is the patient. So if you go in as a patient, you go into your doctor, you may like to have lots of tests done. It may be, I don't know, who would like to have lots of tests done? If you go in for, no? Lots of blood, I don't know, for some people it's kind of comforting to know, especially you'd want to have tests done if you know that they're normal. So if you have a whole bunch of blood tests done, for example, and you know that they're normal, it's quite a nice feeling. So there's no problem with any of this if it gets if it's normal. That's no problem. So you can have 150 tests if they come back normal. That's great. But often they don't quite come back normal. So that's this kind of, it's kind of interesting and confusing. And we used to hear quite a long time ago about I think there were stories from the United States where people like to have for their health screening. So there's a whole question about screening in health when people don't have any symptoms. So screening for various cancers and what's a good screening program and what isn't. But I think this story came from the United States where some people were going in and having, it's like the next stage of a scanning from a CT scan really was an MRI scan. They had MRI scans of their whole body to make sure that they were okay. However, they showed little tumours that came and people didn't know what to do with them. They wouldn't have been found otherwise. And so then it gets into that kind of situation. So okay, then I thought we'll go. Okay, so really this is what I wanted to get out. I think this is close to my heart, and I think it's really important, and we need to go back to basics. That a ground rule, it should be an absolute ground rule in medicine, is that everything should be taken in context. So we were taught in medical school that 80% of the story at least is in the history from the patient. So it's about listening to the patient, it's about listening to their account, it's about getting the timelines clear of what goes on, it's about being clear on the language, it's about clarifying things if you're not clear, and it's about so this is on the kind of clinician side, it's about not assuming things and just getting a very clear story and timeline of what goes on. So if somebody comes in and says they have central crushing chest pain that came 5 to 10 minutes ago and it's going up to their jaw and they're very short of breath, there's no doubt about that. I mean, that's a very clear history, but often it's not clear like that. And so taking a clear and a detailed enough history is absolutely paramount. So the tendency can be to jump in with tests. Jump in, we're going to make sure the patient's okay with tests, but actually really to take a step back. I mean, I think that if you're working in some situations like the emergency room, you are going to want to do a whole number of tests, so we need to be clear on the story, and this helps to kind of be clear. So sometimes it's a good choice not to do tests. That's one of the things. So it happens a bit that, and it's not always the junior doctors, but sometimes the doctors who are, say, starting and they're less sure, they'll do more tests. Of course, they want to be comforted in themselves that they've done everything right, but actually you then get some abnormalities that get thrown up, and it's not always easier to navigate through that. So sometimes you need to be confident enough not to do tests, but it's always a balance. You know, you don't want to be cavalier or unwise. So I thought, okay, so now I thought, so today I thought that rather than split into groups, we'd just go through some examples, which would be, I think, interesting, and then we'll have some time for questions and thoughts afterwards and clarifications. So, as I was saying, there's been a big increase of scans in the last 20, 30, 40 years, with a big increase in the evolution of the technology. It's improved a whole lot. So, as I said, the CT scans previously were coarse, but now you can get very detailed CT scans very quickly. It's led to the discovery of many small tumours. So, management, so for example, a tumour in the adrenal, so the adrenal gland is a small endocrine gland down here, so tumours in the adrenal gland, thyroid nodules, liver tumours, small liver tumours, pituitaries in the brain, and small pulmonary tumours in the lung. So we'll have a case of the small pulmonary tumours. So the thing is that most of these tumours don't progress to do anything serious, but there's a very small chance that they could do. So in a way, for the individual patient, it depends on their temperament a bit, but it's not so wonderful to know that you've got, rather not not have had the scan done, in a way, to know that you've got like a small tumour there. What are you going to do with it? And so the recommendation from the medical people is likely to leave it and watch it and rescan in a year. But if you think that I think it depends on the individual's temperament, actually, on the patient basis, about how you're going to be with something like that. And some people, so there's something called health anxiety, where people worry about things in their body, and apparently that can be in sometimes up to 4% or 5% of people. So if you know you've got something inside, it maybe have you more anxious, bless you. So it's not always, so you see the kind of slight difficulty that gets created here as a byproduct of all of those scans that are done. And we've kind of, it's maybe an inevitable result of the advent of technology. It's an inevitable result, but it does mean that there are tests we don't know what to do with them. So that's number one. Right, so this is a classic one. So we mentioned this one in the one of the last two workshops. So if you have back pain, so does anybody here have back pain? Sometimes back pain. Okay, so so with back pain, you may think, well, it's quite nice actually to know what's going on. I mean, I would kind of think that I'd like to know what's going on with my back. I'd like to know what's going on in terms of the anatomy, in terms of the structures in the back. If I've got back pain, in terms of there are the nerves that go down the back, and in terms of what's pressing on the nerves, if there's a sciatic pain, and it would just be good to know that, because you would think that if you've got the disc that comes out between the vertebra and it's pressing on the nerve, then you would think it would be good to do an operation. So you want to change that, you want to get the pressure off. I mean, that's kind of what I would think in my logical mind. That, however, this is a very important situation with back pains to take it all in context, to take the history from the patient and really to try some lifestyle things first, definitely. So you definitely want to do movements, you definitely want to do things like physiotherapy, you'd want to try painkillers if you can, because the changes that you find on a scan in quite a few cases don't correlate with the management of symptoms. So so you don't just treat the result, because if you just go for the result, often the back pain may not get better. So it all needs to be taken in conjunction with the story. So that's not to say that there are some MRI results where you definitely do need to treat it. I mean, so it would have a change enough that you need to treat it. But quite a few results that are abnormal, if you go ahead and treat the anatomical abnormality, it's not going to make the pain better. Okay, so you need to understand about that story and not just go for the result. Okay, so that's really an important area to listen to the patient, speak to the patient, and do other things as well, not just go for the result. So that's a confusing result, potentially. Okay, this is a classical one. Has anybody heard of PSA? Prostate, yeah. Prostatic specific antigen is a substance that is released from the prostate gland, and classically it will be, so in men, obviously, in males, and it will be high, really high, with prostate cancer. Okay, but the problem with it, so this was a classic case also when they, in previous times, when people had a post-mortem or needed to have a post-mortem, they would often find prostate cancers in there that had no implication on the lifespan of the person they're doing the post-mortem on. So no effect on the life of that person. Those are some prostate cancers. So other prostate cancers do. However, so if you have a raised PSA test, some cancers are clinically insignificant. So even if you treat, then you need to make the decision. So even if it's diagnosed as prostate cancer, it could have been before that. If you left it, it would have been okay. Nothing would have happened for that person's life. If you go and treat it, then the treatments can be a bit invasive, with some potential side effects of the treatment. So that's again a conundrum that we're in. So then it needs to be, how are you going to analyze, how are you going to balance that? And so this is a whole, so some people, so then there was a whole question about, this then leads on to screening tests in the population for people who don't have symptoms. So should it be that, say, every man of 50 or above should have a PSA screening test done? So that's then the question. However, so I know about the UK context, and it's a little bit different here because for people who've got kind of medical insurance, and it may be a bit different in terms of having a PSA test done. But in the UK at the moment, there isn't a screening program for the whole population at the moment, because it's thought that if you have the abnormal results, it can get a bit confusing. But there is screening that's advocated for some people. For example, if there's a family history of prostate cancer, and also it's more common in black people. So if black people, I think that they can have a screening. But we need to be mindful that when somebody comes in and says, "I would like a PSA test done," it's not necessarily the best thing to have a PSA test done, because you may get stuck not knowing. So having an abnormal result can cause more anxiety than not knowing what your PSA is. So it's an area where there are kind of not rights or wrongs, but it is a conundrum. So these are they're kind of little cul-de-sacs that we've got ourselves into. Okay, so then there's a spectrum of the endocrine glands. So the endocrine glands are the glands in the body that pump out hormones to help for the balance and the functioning of the body. So the classical one is the thyroid gland, but we also have the adrenal gland, that's an endocrine gland, the pituitary gland in the brain that secretes a lot of hormones, the pancreas. So who knows what the pancreas secretes? Insulin, absolutely. So that's the classical thing that the pancreas secretes. So with the increased sensitivity of our tests, we can pick up abnormalities in these organs earlier on. So there's something in the thyroid gland. So when the thyroid gland is underactive, it's called hypothyroidism, and that's very clear. When it's hyperactive, it's called hyperthyroidism, and that's very clear. There's the thyroid hormone from the gland is called thyroxine, so it either goes too low or too high. But if it makes sense, it's in a feedback loop with the pituitary gland. So you have the thyroid hormone, you've got the releasing hormone in the brain that triggers the thyroid hormone to be released. So when this one goes up, this one goes down. When this one goes down, this one goes up because it needs to balance itself out. There's something called, I've got a long name, subclinical hypothyroidism, is when this is normal, but this is on its way to going down, but it isn't down yet. But this one starts going up. So that's called subclinical hypothyroidism. Thing is, people don't know when to treat it, don't know at what level to treat it. So there are guidelines now that suggest that when the TSH gets to a certain level. So that's an example of just early detection of the earlier phase of an abnormality of a gland, and probably you could just leave it for a long time and it wouldn't have any implications for somebody. But this is not really a problem, a situation where we get ourselves into lots of big problems with it, because the thyroid hormone is a pretty safe hormone. The one you're going to treat with is a pretty safe hormone. You can have it the opposite, so it goes subclinical hyperthyroidism, and then the medications to calm down the thyroid are a bit more toxic than the thyroxine to speed up the thyroid. So if it goes the other way, sometimes it's not clear when to start the medication to calm it down. But these are examples where we don't really know what to do, because our detection systems are so good. They're just picking up the gland at an earlier stage of probably normality, and we probably get on with our lives before. But that's where the technology. So probably we should be. We're maybe having a good time with our families or doing something else rather than worrying about the results previously. But that's another example. Okay, so there's another example. If somebody has symptoms of a urine infection, so those are typically burning when you go to the toilet, passing urine more frequently, and maybe the stream can change. If you have bacteria in the urine, then that above a certain amount, that's a urine infection, and you give antibiotics for it. You definitely give antibiotics for it, because you don't want to leave it, because then the infection can spread. So that's not good. However, you can have bacteria in the urine without any symptoms. So, and then it's called asymptomatic, no symptoms bacteriuria. So, and mostly you wouldn't treat that, but it can be confusing. But in pregnancy, you would treat that. But anyway, that's another situation where people can get confused. Even the clinicians can get confused and give antibiotics where they're not really required. And one of the problems with giving antibiotics where they're not required is that you can get resistance, bacterial resistance to antibiotics. And that can then make it more difficult to treat with antibiotics after that. So we need to be careful. So generally, as a rule, we want to not treat unless we need to treat with medications. We don't, that's a general rule. Okay. Another example is an MRI scan of the brain. So if you can get, so when people get older, you see small changes in the very small arterial, the small blood vessels of the brain, and that's called small vessel disease. It can be normal as people get older, or it can go with people who are getting dementia. So then it brings up the question, what do you do? What do you do for that? So if you have that, you'd want to give an emphasis on lifestyle, healthy lifestyle, like diet and having appropriate exercise and sleeping well and resting well in any case. But then there's a question, I suppose, of is it worthwhile? Would you consider starting? Well, you need to do a proper assessment with the person, because if their memory's fine, it's not due to dementia. But anyway, it's another area where it can be a bit confusing. So you need to think clearly on the clinician's part. You need to think clearly, and on the other side, on the patient's part, it's helpful to think clearly and to know what the questions that maybe you want to ask the physician about it. So you want to say, is this normal? If you get that, and not think, oh, I've got dementia, when you haven't. So that's another area, a kind of grey area. And just another one. So I think this quite. So there's a test, a blood test called. It's got a long name, high sensitivity troponin, and it comes from the heart muscle, and it can. So if somebody's having a heart attack, it can be raised, but it can also come from some other organs in the body, other parts of the body. So it can be raised for another reason. And then there's the question: are you going to go through all the investigations for the heart, which may be a little bit invasive? For example, doing coronary angiography to have a look at the coronary arteries. That has some risks related to it. So then you've got that question. So it's not, in some situations it may not be necessarily clear. So okay, so any thoughts, any questions, any considerations about any of this? Oh no, that's the case. That's the next case. So we'll come into that in a second. Any thoughts? Any questions about what I've talked about so far? So I've done quite a lot of talking.
Isn't it better to be safe than sorry? Rather have tests.
Okay.
And then catch something early before it gets worse and it's too late.
Yeah. So just remind me your name.
Joey.
Okay. So Joey says, so that's a very good point. So maybe better be safe than sorry, and catch it early before it's too late. So so that means you'll and it depends, doesn't it? It depends what the symptom is. Depends what you go to the doctor with. And it kind of depends on the situation, but you would tend to go, so that makes sense, doesn't it, to want to have the tests. The more tests you have, the more that you may bring up a grey area like this and not knowing what to do. So then you may have a few additional cul-de-sacs that you go into, but as a thought, yes. I mean, it makes sense. Do people agree with what do you think? So you agree with that. So, for example, we're going to have a look at this. So in the UK, they've just started a screening program for people who so PAC means smoking one packet of cigarettes a day for a year. So they've got this screening program for people who smoke cigarettes. When they get to 60, they have a CT scan of their chest. Okay, so that's a screening program. The thing is that they're showing up. Sometimes it shows up these nodules, these small nodules that they're not quite sure what to do with. So better to have the test, but then you may be in an uncertain situation. So, but really the question is, if you want to say have a prostate test done, or one of these areas, but you have no family history, you've got no symptoms, are you going to have the test done?
Yes.
But it's for men. It's for men. Remember, the prostate test is for men. It's for men. So that's the question. So some tests definitely are good tests to have, a helpful test to have done. So like early screening for like for bowel cancer, for example, it can be a really good screening test to have done. Okay, so generally the thinking here is have test everything. Is that right? Okay, so Joey, do you think test everything?
My doctor would like me to go to urologist, heart guy, lung guy. That's what my doctor would.
That's what your doctor would like to do, yeah. And do you have symptoms? You have some symptoms?
Urologist.
Yeah, you have some, yeah.
Going to the bathroom.
Yeah, okay, so you have, yeah. So Miriam.
If you're going to go to every doctor for every test,
Yeah.
I suggest that you put a psychologist, psychiatrist at the top.
Okay, so yeah, so
You're going to have problems.
you're going to have problems. You're going to have problems, especially if you don't have symptoms. I mean, especially, so one of the things that's happening in the is they're doing CT scans of CT coronary angiography, so the CT scans of the coronary arteries. I think they're doing it sometimes as a screening test. In some people you can have that done, but again, sometimes it shows, so you don't actually have to have it invasive, you don't have to actually have the dye in your coronary arteries and have a look in that way, and sometimes it shows changes there, and then it's not quite sure what to do with the changes, so it's done as a screening test, but it's a bit uncertain about the implications of the changes. So I think it will come to be. I mean, certainly in some situations you definitely want to have test done. If you would definitely want to do that, but it's some other situations where it's a bit more kind of grey area. So this is an example. So we'll work through this example of David. So he's 72-year-old smoker, and he has smoked 1 packet of cigarettes a day for 40 years. So that does happen for some people. That's a lot of cigarettes, isn't it? And he doesn't have any symptoms, but he is eligible for the screening tests to exclude lung cancer. So he has a CT scan. That's what's being done nowadays, because definitely if you show a lung cancer early, that can help the prognosis. So one of the problems with lung cancers is it presenting too late. So I don't think many people would argue against having this technology and doing this scanning, and certainly in the UK situation, there's whole screening programs that need to be thought out very carefully. They need to think up the costs and the benefits, because it's nationally funded. So once it gets to the threshold of a screening test, it's had quite a lot of work done on it. However, sorry, I had a picture of a nodule here, but I can't show it there because it's not coming on the screen. But believe me, it shows a 4 to 6 millimeter single nodule in his lung. So it's a little swelling in the lung. Okay, so that's what's shown on the CT scan. So most nodules are not due to cancer. Most nodules that size in the lung. Okay, so okay, there we are. That's it. That's a nodule. Believe me, the little white thing. I think that's the nodule. Okay, so that's what it shows, a single nodule. Okay, so the thing is, right, listen to this fact. In CT screening studies, 20 to 50% of people have at least one nodule. Okay, so I think we need to take that in. So this is part of the issue here. Okay, so we are 20 to 50% of people so it's likely that a few of us have got a single nodule. We know nothing about it. Okay, but the vast majority are not cancer. Like in the 90%, 95% are not cancer. So I'm just trying to, if we put ourselves into his shoes, into David's shoes, he's had this scan done, and he knows he has a nodule, but it's got 1 to 2% chance, maybe in his lifetime, of turning into a cancer. But if you sit with a nodule, how's it going to be for you? Who would just want it taken out? You've got a nodule, it could be cancer. You've got something that could be cancer in there. Do you want it taken?
If it's got cancer or not, unless you take a CT scan.
No, he's had the CT scan. It shows a nodule.
But you don't know if it's got cancer.
You don't know if he's got cancer. Okay. So who would want it taken out? You want it taken out. That's what I was trying to get at. Okay. So
Isn't there a technique called needle aspiration?
yes, there is. I haven't come to that yet.
Sorry.
There is. Okay, so Harold would want it taken out. Okay, so there's a part of me, I must admit. So we're talking about perception of risk again. It's like from the previous talk. It's our initial brains before we developed our human cortex. It's the fight or flight brain. It's called the amygdala. It's our fear response. Emotionally, if we think we've got something in us that may be cancer, I think a few of us may want it taken out. I may want it taken out and know it's not there, and I don't need to worry about it. I don't really like the worry. So actually, You don't know the history here. Oh, all you know is that you've got a 40. So if you're this guy David, you've just smoked a lot. You've got no other lung symptoms. Oh, okay. So okay, that was your. Okay, sure. It depends on the history. Absolutely, yeah. So, you could. So what Miriam said, of course. So you can do a. You would want to know, as you said, Joey. You'd want to know about. So you've only got the CT scan, which just shows the big, like the picture, but it doesn't show about the cells. You need to know the histology. So if you wanted to go ahead with that, you would. So really, the question is, are you going to leave it and then rescan it in half a year or a year or whatever the protocol suggests, or are you going to see if it's definitely cancer? So to see if it's cancer, depending on where it is in the lung, they can do a biopsy or an aspiration, where they take some of the cells of the tissue. But if you do that, so I was surprised at this figure. Apparently the risk, there's something called a pneumothorax, which is when there's an air leak around a lung and the lung collapses. So apparently the risk of a pneumothorax, if you take a biopsy, I mean, it would depend on where it is and a bit on who's taking the biopsy. The risk of having the collapsed lung can be 15 to 25%. So it's a big risk. However, if you've got a pneumothorax, you can then re-expand the lung by putting in a chest drain. So there would be risks of taking the biopsy. So that's really the initial question. Are you going to go for the biopsy, or are you going to leave it, knowing that the risk of cancer is probably 1%? I think in your life, who would leave it?
Don't you take advice from your doctor?
Yeah, you do. So the doctor would say leave it, likely. But if it's in you, what are you going to do? So that's your doctor's advice, but your doctor's not you. So you still got this thing that you know. I think for some people it may be, and as I say, apparently that health anxiety that people have. So health anxiety is when people worry about their body and get into a bit of a cycle of worry. I just think for some people, knowing that you've got something that can be cancer in the body is not a very nice thing, and some people may be more prone to go towards the investigation. Previously, we wouldn't know anything about it, and people would likely be fine. So this is an example of one of those byproducts, really, of screening, of the tests that we feel a bit uneasy with. I mean, I think if it were me, I would try to take my doctor's advice. If it were me, I'm not saying that has to be you, because each person's individual. I would probably do that, and I'd get intermittently scared, and then I'd get on, and then I'd get scared again, probably. But even though, and it's irrational but our brains don't work in statistics. That's the thing. So the statistics is low that it's going to be a problem. But our brains don't work in that sometimes. So that's a case. Okay. Isn't it easier to just have the operation, get it removed? In a way, you think, yeah, just have it. There's a part of me that think, yeah, I'd just like to have it done, move on. No, it's fine. Then you don't have to worry. I mean, because that's what you do with cancers, isn't it? Like if you've got a skin cancer, if you've got skin cancer, have it removed and you're fine, pretty much. Or if you have Sorry?
I said I'm not so sure about that.
Well, it depends on the spread, but if it's like a basal cell carcinoma or a squamous and it's removed. So that's how we think. We think, yeah, great, we've got a problem, have it removed, be mechanical in that way, have it removed, but it doesn't work like that. It's more.
Trust your surgeon to take it out.
Of course. So then there's going to be some operator, some surgeon individuality. So it would not be necessarily an off thing to say to the the thoracic surgeon, how many of these have you taken out? How many of these have you done? You can ask, I mean, if it's not too antagonistic, but sure. Okay. So anyway, so there's that one. Okay, and this is a table, but it's not. Okay, so this is the risk. You see, the bigger the nodule, the higher the risk. So more than 8 millimeters, 5 to 15%. I think they mean cancer risk in your life, not just in the next year. And it goes up. But he had a 4 to 6 millimeter one, so it's a 1 to 2% risk he's got in his life that would become malignant. So probably what he would do is have another scan in whatever long, half a year or a year. The problem is you can't legislate for it transforming in that time. You don't know. Some may change at some point in those 3 or 6 months. Be unusual. But so in some ways you go on the statistics and you take a bit of there's going to be a risk. After it's removed, if it's removed properly, it shouldn't because it's unless it's spread, then that's a problem. So the other, okay, so biopsy complications, pneumothorax, as we said, okay, and then if you go to surgery, there are risks of surgery, so not to underestimate the risks of surgery, including when we get older. So there are risks. Yeah. Okay, so then this one is it's kind of what we've covered, but it's the PSA. So Jeremy's 64-year-old man, presenting for a routine health check. He's well. So he's well, he's got no urinary symptoms. So he's passing urine normally, he's got no weight loss, no bone pain, and no family history of prostate cancer. Should he have a PSA? He wants a PSA test, which is the prostate test, prostatic specific antigen. So he goes ahead and it's raised. So sometimes people have that on like health screenings. They have a full batch of tests done on the private health screenings, like in the UK. That's the UK context. So he has a raised PSA, and he had and part of the investigation, it's a very nice part of the investigation, is the examination is a rectal examination, because you want to feel for the prostate gland. His is normal, and his urine is normal. So the PSA is raised, but it's not doesn't definitely mean prostate cancer.
What's normal for PSA?
I think it's under 4.6, but it depends on the lab. And some labs 4.65, but you just have a look. They will have the normal range for the individual lab. So they should give that with the result. So for the clinician, you think, oh, I may be missing an early cancer, but you're also thinking, but you're thinking, I don't want to over-investigate a condition that is not serious, which may include rather invasive things like doing a telescope inside up the urethra, doing a biopsy of the prostate gland, which can have some complications, with risks of infection or bleeding. And then there's the problem of detecting clinically insignificant cancer, which was the case when they did those post-mortems previously. and people, you notice clinically insignificant cancer that didn't do anything in the patient's life. So that's a situation where you get a bit stuck. What are you going to do? You have to you discuss it with the patient. It's not clear cut, and you discuss the pros and cons of and partly you may be, if the patient, if Joseph really wanted the investigations, you may just go ahead with that, but as long as he's aware of the that there are some complications that can come with it.
The cancer's worse. Having cancer's worse than those.
Well, it may be, but you can also have a lot of prostate cancers that are very benign. But the cancer there could be a small chance, but probably unlikely with a PSA at that level. It's not a very high level. It's just, so if that PSA were a lot higher, you would be more focused to need to investigate. It's in a kind of grey area. So it's a bit tricky. It's a bit tricky. But you can't definitely, as the clinician in that kind of situation, tell everybody you should go ahead and have a biopsy, probably, because of the possible side effects and risks and the statistics of the numbers of cases that won't be cancer. So then you wouldn't be, so it's all a balance, but it's also what the individual wants, and it's for the individual, this is a situation where the individual patient would need to understand the pros and cons of doing either thing. The risks of having cancer if they don't, the risk of the investigations if they do, and the percentage chance kind of having cancer. So it's not so clear cut. So the problem is PSA is sensitive, so it will pick up. Most of the cancers will have a raised PSA, but it will also be raised with other situations. For example, a urinary infection or some other things related to the prostate. Many detected cancers are indolent, as in benign. Many of believe it or not, so these types of cancers, many of them are benign. They won't do anything to you. And biopsy and treatment carry real harm. So this is not so straightforward. You kind of caught a bit between two stools. So that's it. That's a run through the those kind of grey areas. So any thoughts, any questions, any clarifications, any?
Well, I'm told if we're over 50, we must go for a prostate.
Oh, are you told that?
We're told that by every doctor, chemist, dentist. All tell us.
To go for a PSA?
Because you're over 50.
To go for a PSA? Okay. Well, that's interesting, but it could possibly be, so certainly if there's a family history, and certainly with symptoms, definitely with symptoms, and definitely, and so black people have a slightly higher incidence. I'm not sure. So if you have the BRCA gene as a Jewish person, then you have a high incidence of prostate cancer. I don't know. I don't think, but I'm not absolutely sure if the incidence is slightly higher in Jewish people. But there can be pitfalls. So it's not. So if you have a PSA test done and it's normal, that's great. Okay. So that's really the situation that you want. But if you have one that's in a grey area without symptoms, it may be a bit confusing. So then you need to ask yourself, check in with yourself and with your clinician about how you want to go forward. So, and if you go forward, you're essentially going to have a prostate biopsy and an MRI scan. So MRI scans, not much risk from an MRI scan, but prostate biopsy, you can get some bleeding afterwards. So you'd want to know the statistics if you're in that grey area, and then you'd want to have that degree of information, and then you want to make your decision based on that, and also based on the discussion. So it actually means a longer consideration for you as a patient, and a longer consideration and discussion with the doctor, if you're in the grey area. And if you're clearly normal, you're clearly normal. If you're clearly abnormal, above a certain level, I don't know, 10 or something, or 8 or whatever the figure is given, then you're abnormal. Then you need to go and have the investigations. When you're in the grey area, that's what we're talking about. No. So if you're in the grey area, then it's grey. So it depends on you as an individual. It depends on the discussion that you have with your clinician. It also depends on how your clinician is kind of conveying the information to you. So that can be an area where it could be an area where, if it's slightly raised and you choose not to have the investigations, but then you would have the test done again, then it may not rise. It may just be fine, and then so that's the kind of. Yes, Brian. Yeah.
I had 2 coral pops.
Yeah.
I found it broke.
Yeah.
And I did whatever they had to do.
Yeah.
The second one, and my doctor said, in no circumstances must I have an op because of my age.
Okay.
Over 80.
Okay. So the doctor said that. So he was weighing up, and then is it all treated now?
It's being treated, but he said, in no circumstances must I have an op because I don't have any problems with the second op.
Okay, but they did it. But they took the. Did they take biopsies, or did they take the polyps out?
I took the polyps out.
They took them out. So maybe they were happy.
No, but he said you mustn't have any ops my age.
Okay, but is it treated and cured now?
It seems all right.
Yeah. So that was maybe a safer way to do it.
But he said, and he wasn't just talking about that. He was saying any of a certain of a certain age, you don't age is important.
Age is important, and anaesthetic risk and risk of operations are important. However, God forbid it doesn't happen. However, if you needed a critical operation, if somebody had, God forbid, a burst appendix, that's a life-saving operation that needs to be done. So as in, if you have a burst appendix and that isn't mended, you will likely get septicemia and succumb to that. So then there's a big so then that needs to be balanced. So there are some times when an operation obviously is critical, and then that all needs to be weighed up and discussed. Yeah.
He wasn't keen on my age.
Sure, but so that's all like a determination, a consideration, and analysis of the risks of an operation. But that's fine. So it sounds like you did fine with it, and those were removed. So that's all a balance. So that sounds reasonable. Was this interesting to look at these areas? Yeah, I thought it was interesting. It kind of came to me. I thought, what will we do for this one? I thought it's interesting because it is something that we do deal with from time to time. We definitely deal with it from time to time as clinicians, and it is not straightforward. And I think medicine's going the way that kind of medicine's going. Investigations are happening, but it can create more worry for people in some circumstances when they were having fun before. That's part of the thing. So it's important not just to be So sometimes we have to do lots of, investigations and they're critical, but it's important not to be too investigation orientated. You need like the bigger balance for people's, lives, So generally, if it's something like with the musculoskeletal thing, or your back, or bones or muscles, you generally want to be moving as you can, generally, depending on and then physiotherapy, are really helpful things to have. So any of those things to support what's there. Any other thoughts or questions, or maybe any individual experiences, or? No, we've had it. Yes.
In January, I visited my doctor, routine checkup, age 83, and various blood tests were done.
Yeah.
By and large, the only one that seemed to be of immediate concern was a slightly large liver, and the comment was ultrasound demonstrates, I can't pronounce this electronically, with no suspicious liver lesions.
Okay.
Now, the doctor never came back to me, and the common sort of comment, particularly with a busy practitioner,
Yeah.
is if they don't react immediately and find immediately, it's not serious. Leave it at that. Have peace of mind, not to worry. And that's where I am at the moment, and despite the fact
Okay.
that just give us a message on the intercom, anything.
Yeah, that would be helpful, wouldn't it? So it means that the liver's a bit large.
Yeah.
And was that an ultrasound scan? Ultrasound. Okay. Yeah, not a CT scan, an ultrasound. Okay. And that's all that. I mean, so I would follow up, if you can, with the doctor, just to see if they think that anything else needs to be done, and maybe there isn't anything else that needs to be done. Did they do blood tests? Yeah. I think I would just follow to see that they're happy and that nothing needs to be done.
One just feels reassured if one gets feedback.
Yeah, you do.
Even if it's 3 words, nothing to...
Exactly. So I think that's really part of the role of the clinician, to give some feedback on that. So hopefully, if you'll be able to get that feedback and then have peace of mind with that. Yeah. Yeah, I agree. So it's important, because otherwise you're left not knowing, and that's not good. So that's what we try to do. I mean, that's our aim. That should be our aim, where we work to reassure people or give clear information. Yeah. Give information. Yeah. So if somebody arrives in hospital unconscious, origin so you don't know where they come from, they come in, who takes them in? How do they?
You don't know what's wrong with him.
Oh, okay. But they're brought in by relatives or something. Okay, what do you do? Is that the question? Panic. So it is. So after you've panicked, hopefully you don't panic too long. Right. So one thing is that's not the field where I work, because I'm in general practice. In fact, so I think that there likely are standard procedures for that. There must be, because Okay.
Shouldn't they give a diuretic cortisone and enzyme?
Not necessarily. So I'm just thinking from first principles. This is quite a while since I worked in that emergency room. So you want to get the diagnosis. You want to get the diagnosis quickly. So the first things you want to do, always ABC, airways, breathing, circulation. So you want to make sure that so that the airway, that the patient's breathing and that the heart is beating. So always airways, breathing, circulation. Once that's okay, if they're unconscious, you then, I'm sure you would want to. There are various pain. So there's a coma score. So you want to do all that analysis. You want to see how much coma they're in. And then you'd want to take their vitals, their blood pressure. You want to examine them quickly. You want to get some help. You want to do an ECG immediately. You want to make sure they haven't had a big heart attack. You'd want to take some. You want to take some blood gases. See the oxygenation of the blood quickly. I'm just thinking you want to take bloods quickly. You want to see if they're infected. And then there's going to be, there likely will be a protocol for what you're going to give. So you're likely going to give oxygen, and you're likely going to give, I know there'll be a protocol. If it's thought that you give a whack of antibiotics, I'm not sure what people would do. But you.
What I noticed in the casualty is they also include, almost immediately, X-rays and CAT scans.
So X-rays and CAT scans. So that is, yeah. So you would, yes. Yeah. So I think, no, you can't. No, you can't. Or else you're. You have. I think you've got to actually stand. You've actually still got to stop, stand back, analyze the situation, even if it takes you 20 seconds. And then go according to a protocol. So it's quite important to be sequenced. And of course you would do the scans, because it could be due to internal bleeding that you just haven't seen, for example, or a collapsed lung or something. So that there should be protocols in that way. And otherwise you're acting blindly. So you would pretty much always give oxygen. I mean. But otherwise you're acting blindly. And you don't want to do, I mean, if there's any chance of a mechanical trauma, you want to be very careful with the neck. You don't want to cause, that's fine. And that's from watching Chicago Hope. Actually, is that?
What I've observed in real life, watching real life, is that they do have protocols and procedures. There's certain things that
Of
get
course.
done immediately,
Yeah.
and certain things that get done second.
Yeah.
They're pretty issues to.
Because it's that.
Most people survive emergency.
Yeah.
So then it's too late.
No. So there are a few situations where you absolutely need to act then and there. So if somebody's got meningococcal meningitis, and it's spread and it's got into the system, you need to give antibiotics then and there. But you will see the signs of that. If somebody is hypoglycemic, you pretty much need to give some sugar infusion or glucagon injection, but then you will have checked their sugar at the time. So you don't want them going...
It's a 10-second test.
It's a 10-second test. So that kind of thing. If somebody's unconscious, they need a CT brain scan, because they may have bled into their brain. Yeah. Yeah. Okay.
But they'll see that on the blood.
They'll see that on the scan.
Well, then if it's too late, it's too late.
If it's too late, it's too, yeah.
Passed away.
No, unfortunately, that is one of the causes of sudden death, unfortunately.
There's nothing they can do.
No, if there's so much bleeding, you can't. Yeah.
But there are protocols, absolutely.
Yeah, I'm sure. I'm sure there are. I'm sure that there are protocols. There has to be, because it's that kind of a situation that absolutely lends itself to protocols. I mean, so you need to be. You don't want to be. You don't want to be. You can't be over emotional in that kind of situation. You need to be very systematic in the way that you're working through things.
Said he's describing something from 40 years ago. I'm saying that description is irrelevant because the advances we have today.
Yeah, the advances are huge. So that's where scanning. So pretty much in our urgent care, A&E, loads of people have CT scans, CT brain, CT body. I mean, and that's part of what's showing getting these grey areas out. It just is because of the numbers of. If you think 30 to 50% of them are of the chest ones are gonna have little nodules.
But even here in South Africa, with our record for bad medical care in public hospitals, there's always a CT scan available.
Yeah. So I suppose that. I suppose CT scans that they're really good in that they're scalable. You can, lots of places have them. You can take the scans quickly. They're detailed, and even sometimes the reading of the scan can be done remotely. You don't necessarily have to have somebody physically present there because it can all be on the computer.
And they can bring the scanning machinery to you.
And they can bring the scanning machinery to you, yeah. So, and so I suppose scans are used so much because they are non-invasive. You don't need to get into the body. So, even like for things like appendicitis nowadays, they do scans as well, and they will show, clearly what's going on.
Do they use microsurgery for appendicitis?
I think so. I think they do, like laparoscopic surgery, yeah. I think they do, but I don't know if somebody had like an appendix that's burst, you'd probably, I don't know if they, no, they can't do that. But I think they can do laparoscopic surgery, yeah. Yeah. So, that's the grey areas, thank you, everybody.
And guys, I really mean it. If you have all these concerns, you better take a psychiatrist with you.
Okay, good. So that's the third of these three. Hopefully, it's given you some food for thought. Hopefully it's given you some food for thought and also like informed you a bit so that if you encounter situations like that, then you feel more confident. I mean, that's the hope. That's my hope. Okay, so we're finishing. Okay, so that's okay.
Another symptoms, but
Okay, yeah. I think Google it, yeah. Thank you, everybody.